Good evening. Welcome to BlackDoctor.org. I am your host, Shamika Rhymes. Let me know in the chat where you guys are watching from. So today, February 7th, is National Black HIV and AIDS Awareness Day, and it's a time to raise awareness about the ongoing impact of HIV and AIDS on the Black community. So despite advancements in treatment, the Black community still faces higher infection rates and greater health disparities. And so here on BlackDoctor.org, we're coming together with some amazing experts and panelists to talk about promoting education, encourage testing, and reduce the stigma. We're committed to empowering you all with the knowledge and resources that you need to take control of your health. So please drop any questions in the chat as we go along. Thank you. Let's see here. We've got, I see you guys in the chat. All right, so let me introduce you to tonight's panelists. So first up, we have Dr. Ulysses Burley. He's the founder of You Be the Cure. It's a proprietary consulting company on the intersection of faith, health, and human rights. Welcome, Dr. Burley.
Thank you for having me.
And next up, we've got Dr. Keith Crawford. Dr. Keith Crawford is currently a program officer in the Therapeutic Research Program in the Division of AIDS at the National Institutes of Allergy and Infectious Diseases. Welcome, Dr. Crawford.
Thank you very much for inviting me. Happy to be here.
Oh, and I forgot to mention, you also write for BlackDoctor.org.
I do. Yes.
Dr. Dante Morrison is here with over 20 years of experience in community engagement and servant leadership. He is a dedicated advocate for the wellness of marginalized communities, particularly individuals who identify as LGBTQ. So welcome, Dr. Morrison.
Thank you so much. Appreciate it.
And then we've got Reverend Ray Lewis Thornton, Emmy award-winning AIDS activist, and she's the author of Unprotected, a memoir. You guys may remember her sharing her story on Essence magazine a while back. Welcome.
Thank you. Thanks for having me.
And then our last panelist is Tammy Kinney. She is a HIV patient advocate.
Hi,
Tammy.
I am really excited about this conversation. Thank you for having me on this panel.
Thank you all for joining. So I want to remind everyone in the chat, don't forget to drop your questions and let us know where you're watching from. So we're going to kick this off. Dr. Crawford, I'm going to start with you. Can you provide an overview of how HIV and AIDS has disproportionately affected the Black community?
Yes, I can. So an overview, one way that, or the way I like to look at this, having been involved in this since we first determined that this was a serious medical problem, is that it's kind of been a perfect storm. It's been a perfect storm with stigma. It's been a perfect storm with medical racism, and also what we refer to as social determinants of health. So I'll just start with social determinants of health. This determines whether a person has medical insurance and whether they can access care. It includes whether a person lives close by a facility where they can get medical care. Do they have access to a pharmacy? It depends on whether they have medical leave. So if you're sick, do you have time off? All of these are factors that influence our access to care. When we talk about stigma, HIV is a disease that's heavily stigmatized. It is a disease that got labeled as a gay disease or affecting LGBT individuals at a period of time where there wasn't a lot of respect for the rights of LGBT people. And then there's the issue with medical racism, where even people coming into care, into the medical system, were not getting the same treatments or necessarily the same care based on their race. So that's why I say it's a perfect storm, because all of these different elements contribute to disproportionate outcomes in African-American communities.
Okay, thank you. Dr. Burley, Dr. Morrison, do either one of you want to add to that?
No, I think Dr. Crawford covered it well.
Yeah,
Okay.
great summation.
Okay. And this question, I'm just going to go around the room because I think everybody can answer this one. What are some common misconceptions about HIV and AIDS within the Black community, which you already mentioned some of those, Dr. Crawford, and how can we address them? So I'm going to start with you, Dr. Burley, and then we'll just go around.
So I think one of the misconceptions is that Black people don't care about their health,
Mm-hmm.
don't seek out HIV education and information, and that we don't want the best resources and opportunities for us. And this was something that we saw manifest during COVID-19, where if Black people had questions about a vaccine, society used that as an excuse for why Black people then didn't deserve the solutions for COVID-19. And we see that a lot with HIV because Black people have questions because of historical bias and medical abuse against communities of color. And so I think we have to understand that Black people care about their health just as much as the next community. But that because we've been so disenfranchised, because we've been so traumatized by the healthcare system and the public health infrastructure, we often are skeptical about participating in it. And oftentimes we need to hear from messengers like those in this panel, people who share lived experience, people who look like the communities that are greatest impacted, to further understand what it is that they are participating in so that they can go and access it. So, I think we need to debunk the myth that just because Black people have questions and just because we are skeptical, that our mistrust doesn't necessarily mean we do not want the solutions that are available for us.
Thank you. Dr. Morrison.
I think another misconception is that a lot of people in the Black community think that Black gay men are hypersexual. And that all we do is walk around and have sex every day, all day. Like we don't go to work, we don't do nothing else. We just have sex. And I think that is a huge misconception, and it labels a certain subset within the Black community as just being overly promiscuous and at high risk for HIV. And we look at a lot of the data that's always released, it shows that 1 in 5, 1 in 10, 1 in this. So it puts this target on the back of Black gay men to make it seem like any kind of intimate act that you engage in, HIV is right there knocking at the door. But people don't understand that a lot of Black gay men are not having sex. They actually are celibate or they're in monogamous relationships. So I think just debunking that notion that all Black gay men are just highly promiscuous and overtly sexual, that should be debunked as well, because that is a huge myth.
Thank you. Dr. Crawford, did you have any additional misconceptions you wanted to mention?
I think an important misconception, and I think fortunately people are better educated about this now, but understanding that HIV, when it is managed, when you get into care, when you get effective therapy, this is a chronic manageable disease. This is a disease that is like diabetes, it's like hypertension, it's like asthma. You take your medications properly, that you can live close to what would be a normal lifespan. And what I've seen when I was actually treating more patients were many patients have multiple comorbidities, other diseases, not just HIV. They also have diabetes. They also have COPD. They also have bipolar disease. And oftentimes the HIV disease is under control, but these other conditions are not well managed. And so it's a chronic manageable disease, but we have to manage the whole person. So if you have other medical conditions, we want to manage that too. We have to treat the whole person, but this is a chronic manageable condition or disease.
Thank you. Reverend, I keep wanting to call you doctor as well, but Reverend Ray.
I'm working on it.
Reverend Ray, could you just briefly share your experience, but then also talk about some of the misconceptions you face? Because I think it's important from a patient perspective to hear the things that you also heard.
Well, I think at our baseline, there's still the stereotype of who gets HIV and how someone gets HIV. There's always someone that believes that it's someone other than me when it actually is us that are the ones that are infected with HIV. And when and I know this, I did a panel, I can't name them, but I did a very private panel with a very wealthy small group. And this was like a month ago, and I talked to them for about 15 minutes. And then I paused and I said, who can get HIV? And they all said, anyone. And I said, can you look at a person and tell? And they all said, no. And I said, are you sure? And they all said, yes. And then I said, well, no one's surprised that I have HIV. And they were like, for real? Like, you really got HIV. This ain't no joke. I'm like, yeah, I really have HIV. And I think connected to what was said earlier is this misconception that you're going to know that you're HIV infected when in fact you're not going to know that you're HIV infected. You're not going to know that your partner is infected unless you go get tested. And so, we have about 38% of newly diagnosed cases of people with HIV infected by people who don't know their HIV status. And they're still, which unfortunately for African Americans, we disproportionately learn of our HIV status when we've already progressed to AIDS. And so we're having symptoms of AIDS, not symptoms of HIV, because there are no HIV symptoms. So you're starting to lose weight. You're having maybe wasting syndrome because you're starting to lose weight. You lose your appetite. Women start to have gynecological, issues like recurrent yeast infections. And what woman doesn't think a yeast infection is not normal? And so, along with who looks like, or I can tell someone is HIV infected, it's this understanding that if I had it, I would know because I'm not sick. Last thing I want to say for that point, I was diagnosed with HIV. I was infected with HIV in 1983, I believe. I was tested found out I donated blood in 87, found spring of 87, and learned of my HIV status. The HIV antibody test was a couple years old then. But I didn't transition to AIDS until, when we do the math, that 8 to 10 year timeline. And so I didn't get sick until 92, 93, 94 was my peak of being ill. And 96, I almost died. So still here.
Wow. Thank you for sharing that. And I'm glad you're still here too.
We are all glad.
Yeah. Tammy, can you also share your story and any misconceptions that you've dealt with?
Yes, and I think I'm going to go a little deeper because I am from the rural area. I am a woman living with advanced HIV for 38 years. I was diagnosed in 1987, and I didn't have any bad experiences with my journey, no more than what I brought on myself. But I remember hearing stories like all Black women do is have babies, have sex, multiple baby daddies. No wonder they got HIV. I'm also in long-term recovery. This year will be 15 years. I've been clean and sober. I am so proud of that. Even through my journey with living with advanced HIV, I always was concerned about my drug use. I thought that's what I was going to die from, but evidence is proven it is a way out. But Black women has always been stigmatized when it comes to this is what Black women do. They have sex all the time. Or if they're using drugs, that's another vulnerability for Black women to um, contract HIV or transmit HIV. I think Dr. Crawford said it best. We don't, the conception that people have about Black women, we don't take the time to see about our health. We wait until we get sick and then we go to the emergency room. We use that as a doctor. Well, that's because some women, some folks in the Black community don't know how to navigate the system to get insurance. But I know that's going to come up later. But the different myths are, I think that Black women have been misunderstood throughout our whole generation of life. And we have not been treated the way we need to be treated when it comes to our health and in the healthcare arena.
Let me add, just like Dr. Crawford talked about, I think it was Dr. Crawford talked about this idea of a hypersexual gay men. We still have this. Even women have this belief that, oh, I won't get HIV because I'm in a monogamous relationship, or I don't have sex like that, or that's not me, I'm not no hoe. And the and even when I speak at college campuses, I get the question, how many men that you have sex with? I'm like, why do you want to know? It's because they're calculating their sexual partners against my sexual partners to see how close they are to me. And the fact of the matter is, this only takes one person to infect you. But we live in women, we date, we meet a guy, we think he's wonderful, then the bread molds and we cry about it and we go on about to the next guy. And if you start, say you start at 20 and you don't get married until you're 40, that's 20 years of dating, 20 years of in and out of relationships. And none of it has to do with promiscuity. I mean, I've never had a one night stand. Yes, I've had sex with some knuckleheads that I wish I could take it back, but you can't take back the sex. And so we're still stuck in that. And I think it is, in a larger sense, connected to this hyper image of Black women from slavery and Black men from slavery. So what we experience have been handed down to us through generations and generations, that we have to prove to white people that we are not what they say we are.
Yes, thank you. Anybody want to comment before I go to the next question?
I do want to say this. Thank you for saying it, Reverend Thornton, because that's a part of our trauma as well.
It is.
And that's a part of people not willing to share when they get involved in a serious relationship, that, to give the other person a choice to say, okay, it's okay. You can walk me through, you can educate me, it's fine. Or I don't think I can do this right now. But the shame and the guilt that we have had over generations of being Black women and Black men, it makes us difficult to do the things that we need to do for our own health. So I could see that, yes.
I mean,
and
I could talk about this all night. I mean, this is my topic. I mean, I grew up in a household where I was told I wasn't never going to be nothing. Really, she said something else. I grew up in a household where I was sexualized. That I was an adult survivor of childhood sexual abuse, and then I was sexualized in the way that little Black girls are sexualized. And so, I was told so I was fast from the time I was 6 years old, go sit your fast self down somewhere. And my mother who raised me was the last person I told. In fact, I kept my infection a secret until my T cell count was 80. Okay. And so I did not want my career to be impacted. I didn't want to tell my mother. In fact, I told her 2 weeks before Essence magazine came out. And if I could have figured out a way to be on the cover of Essence without her knowing.
And I don't think we give ourselves enough credit that we are the evidence. We survived. I've never had a doctor to tell me you weren't gonna make it. Once you reach 5 years, your life. I've never had that told to me. But my colleagues and my friends and people I love, they have been told the stories. So I think we should celebrate our life as we see it for those who are living with HIV and advanced HIV. When I was diagnosed, my T cell count was 11. Um, I heard about HIV, but I was living a lifestyle like, I just heard about it. And I really never focused on my diagnosis because I was focused on other things. But I managed through support groups and doctors, and I'm here today. So we are the evidence that what they was telling us back then, telling others. Some believed it, and it took their lives. Believing something that was untrue when it came to the HIV epidemic. We've come a long way and we have survived, and we should be celebrating that.
Thank you for both of you being so transparent and open. And I see people in the chat saying thank you for sharing your stories. Let's go back to Dr. Crawford. Why are people living with HIV at a higher risk for cardiovascular disease and certain cancers, since you mentioned a list of some of the other things they may have going on in their bodies?
So one of the really phenomenal things about the antiretroviral therapies that we have is that they do significantly prolong life. We can get the virus to undetectable levels, which means, of course, it can't be transmitted through sex or through sharing needles or other mechanisms. That's a very good thing. HIV is an inflammatory disease. It causes changes in the body's physiology, and the way the immune system reacts is through this response that we call inflammation. And so when you think about this inflammation, if you look in the blood, you'll see some of the same types of chemicals that we might see in a person who has rheumatoid arthritis or lupus or this inflammation. What this tells us is that there's some damage going on. There's damage as a result of the infection. When we give the medications, the HIV drugs that suppress the virus, this inflammation goes down a lot, but it doesn't go away completely. So we've got this lingering inflammation that's going on. And over time, this can cause problems, say, for example, in the blood vessels. It can cause a condition that we call atherosclerosis. And so what this means is that we have to be super vigilant. These are discussions that you need to be having with your medical provider on how to minimize your risks for this condition, for atherosclerosis. This means that if you have high blood pressure, you got to control it with the medication, staying on top of your blood pressure. We did a study at the National Institutes of Health, and let me just say that everything that I mentioned, I'm not wearing my NIH hat. So you don't go back and say, well, the NIH says such and such. No, NIH didn't say anything. Dr. Crawford said it. So this is my experience, my perspective, not the NIH official response. But we did a study where we used a type of drug that we call a statin. You've probably heard about these statins. They lower cholesterol. They lower triglycerides. They control some of the lipids, the cholesterol, triglycerides that can cause harm. And we gave this particular statin to people living with HIV. These are people living with HIV who were not considered at risk for adverse cardiovascular events. What do I mean? I mean that these are people, if you went to your doctor and you said, well, doc, do you think I'm at risk for having a heart attack? Do you think I'm at risk for having a stroke? Okay, well, let's look at all the different factors. Look at all the factors. Look at your lipids. Look at your blood pressure. Look to see whether you have diabetes. They'd say, no, you're not at risk. These were low risk individuals living with HIV who received the statin, and they compared it to low risk HIV people living with HIV who didn't receive the statin. And what they observed was that the folks who got the statin had a 30% reduction in adverse cardiovascular events. What are adverse cardiovascular events? Just like I just said, a heart attack, a stroke. So giving these individuals this statin reduced their risk. And again, these are people that we're not thinking are at risk.
Mm-hmm.
And so this is kind of a signal telling us that this atherosclerosis, this inflammation, may have been a bigger problem, or may be a bigger problem than what we were thinking. The way this study was done, this is a multi-center clinical study. And when I say multi-center, this study was literally done on every continent. There are research centers on every continent. And so this is an intervention that you might want to discuss with your medical provider as a way of reducing risk for what we would call adverse cardiovascular events. But this is another reason why it's important that people living with HIV have a very healthy diet, engage in physical activity and exercise, and do everything that you can to opt good mental health. And if you have other medical conditions like asthma or diabetes, again, maximizing your control of those other medical conditions as well. And I'll just stop there because some of the others may want to comment on this.
Yes, thank you. Dr. Morrison, Dr. Burley, did you want to comment on that? But I do have another question for both of you coming up. So,
No, I'm good.
okay, well, Dr. Morrison, I have a question for you. What are some of the most effective prevention strategies that you can tell us about, and how can Black individuals learn more about these options?
That's a loaded question. I think prevention strategies comes in different forms. I think one strategy right now is just this conversation, because what people don't know, they don't know. And as Tammy and Reverend Thornton were speaking, and they shared their year of diagnosis, you know, I guess I'm the baby on the block. I was diagnosed in 1999, but hearing them talk, I was like, one thing that is missing now is that level of awareness, or heightened awareness, like we saw in the 90s. Because for all intents and purposes, you can look at the bottom row of the screen, and like Reverend Thornton said, people are like, wait, what? You got HIV, but you don't look like it. because it's safe to assume that at one point in time, there was a quote unquote look to being infected with AIDS or HIV because of the wasting, because of just the fatigue, all that stuff. It had a look. Right now, there is no look of HIV. So there is a disengagement in prevention. That people are detached. They don't feel like they're looking like, well, if I do catch it, I will still look as good as Tammy, Ray, and Dante. So what's the big deal? But they don't hear the Dr. Crawford messages about all the other things that comes along with having HIV. They don't hear about all the other stuff that we have to deal with and unpack. So I think these kind of conversations should be included in prevention toolkits. Now, of course, we have condoms. Yes, we all know about condoms, but there's a reason why people are not using condoms. And that goes back to well, I don't want to use a condom because now I'm inviting HIV to the bedroom and I want to have a free time in that space. Because every area of my life, I have to be on defense, especially those of us that live at the intersection. It's like, well, if I drive down the street as a Black person, I got to be guarded for the police. If I'm a woman, I got to deal with this, can I say it, new administration and what's going on. If I'm gay, I got homophobia in the church and all that. In the bedroom, can I at least throw the condom out the window so I can just be me in this safe space? But all of that stuff, holistic health is prevention. And I think we missed that because we push the condom message. We push the PrEP and PEP. We push the biomedical. But we have to get into the mental of people and understand why they are avoiding condoms, don't want to get on PrEP, don't seek out PEP, don't want to get in treatment. It's something up here that we have to tap into and use the mental as a prevention technique. That's just a different approach that I believe we need to start incorporating in these conversations. Where is your mind at?
Can I say something? I want to piggyback on what Dr. Crawford said. At this meeting I was at, this training I was at, the question was, so I can take HIV medicine for the rest of my life. And then I had that conversation with them about inflammation. I also want to add that HIV also destroys the bone. And so for me as a woman, I'm kind of the borderline osteoporosis. I'm already taking osteoporosis medicine to help my bone health. And so, I mean, there are other things that, like living with part of the problem is that pharmaceutical companies made us think that climbing a mountain and everything will be okay. And the fact of the matter is honey, but the reality is that HIV, yes, we can keep you here, but it's a difficult disease to deal with. You have to be on top of your regimen or you set up a resistance. And then as you age with HIV, we have this whole sense of the inflammation, the bone disease. I mean, there's a lot that happens with a person. And then the emotional health that comes with the weight of carrying this disease, because stigma has not helped us. So it's still, I'm sure Tammy could say, being in a rural area, we still are kind of stuck on stupid with HIV. And I know women don't want to I know that there's a whole generation of women that heard me speak in their 20s who are now in their 40s and they have condom fatigue. It's like, I ain't met my Mr. Right yet, and you saying I still gotta ask a dude to use a condom? Yeah, you do.
So could I just comment on just a couple of things? One, the bone disease, the osteoporosis, as we know, the face of HIV has changed. Older individuals, now probably more than half of people living with HIV are 50 or above. In many ways, that's good news because it means that the people who were infected much younger Thankfully, through the medications we have, those people have lived much longer. But, older people have sex too. So, or may have a substance use disorder and share needles, but older people also can get infected. So we have older people. So the bone disease becomes an issue. There are some medications that use to treat HIV that can cause bone loss, but there are versions of that same drug that actually preserve the bone, actually protect the bone. So these are things that your provider can work out and discuss with you, looking at your entire medical profile and choosing a regimen that is safe. We have enough drugs that we can put together regimens that are safe. With the PrEP, we talk about prevention. Yes, condoms still work, and condoms protect you from multiple types. They protect you from hepatitis. They protect you from bacterial infections like chlamydia and gonorrhea, and of course, protect against HIV. PrEP only protects against HIV, but it can do that very well. And we have choices. We have options for PrEP. Some people don't mind taking pills. So we have PrEP, we have Truvada, we have Descovy, which are pills that people can take every day to protect them from getting HIV infection. We have injectable PrEP that works very well. We have injectable cabotegravir. You see the commercials on TV. This is Apretude. It's given every 2 months. You may not want to take pills every day. So you can get an injection that will last 2 months. We have injectable lenacapavir that lasts 6 months. We did the study in South Africa among young African women who are among most at risk, the highest risk for acquiring HIV infection. And in that study, injectable lenacapavir was 100% effective in preventing HIV infection. So we have a spectrum of options. You can use condoms. You can use PrEP, oral PrEP, injectable PrEP. And now we even have a way to protect against other sexually transmitted infections like chlamydia, like syphilis, like gonorrhea. And this is a process called doxyprep, where a person can take a single dose of the drug doxycycline after they've had sex. And this can protect, in many instances, against other bacterial sexually transmitted infections. So there are lots of options, but we have to find providers who are willing to discuss this, because as Dr. Morrison will probably tell you, a lot of Black gay men in particular, Latino gay men, are not able to gain access to PrEP. It's underutilized. People who need it, people who can benefit from it, cannot find providers who are willing to prescribe it. So this is a challenge. This is a challenge because it results in racial disparities in terms of acquiring HIV. And I'll stop because I've said a lot.
Thank you. I wanted to make sure we get this question before we run out of time. Dr. Burley, how often should individuals be getting tested for HIV? And, we mentioned earlier about rural areas and stuff, and where can they access free or low cost testing?
Yeah, thank you for that question. So the guidelines really are based on identity. And so right now, the guidelines for cisgender heterosexual men and women are not necessarily great because of a lack of evidence around those demographics. For same gender loving men, the guideline is at least once a year. My personal guideline for my patients and my clients is at least once a year. I am a married man of many years, and every year when I go and get my annual, I ask for a full STD panel. And it has nothing to do about my marriage or my trust of my wife. It is a practice, it's a habit. It's one that I had before I was married. It's one that I'll continue to have. And it's one that I advocate for in my patients and in my communities. And so once a year for sure. As folks age, the guidelines become less stringent and they become based on risk. But as Dr. Crawford mentioned, people don't stop having sex once we age, thank God. And people who continue to use substance use when they age. And this is a blind spot for a lot of clinicians. A lot of people over the age of 50 will go to their doctors, and their doctors won't recommend that they get tested for HIV or other STDs. And that's a social construct, right, that we have to deconstruct even in our healthcare settings. And so, as a person, you have to then advocate for yourself when you go into these patient rooms to say, hey, I need to get an HIV test. And oftentimes your clinician will be like, oh, you don't need to do that because of whatever they've decided about you based on your profile or your age. And you say, no, I think I do. And I think so that's how we kind of have to co-labor in this work together with clinicians to make sure that we are covered. I want to backtrack and add to the conversation about prevention. I love Dr. Morrison's framing around prevention as a spectrum, and that information and education can serve as a way of prevention. And then Dr. Crawford added to that with the biomedical tools that we have for prevention. But the one thing that's still missing from our prevention toolbox is an effective vaccine. We have never eradicated a disease without either a cure or a preventative vaccine. And we don't have either for HIV. And I don't believe that we will end the HIV epidemic with antiretrovirals alone. And so my colleagues and I at the HIV Vaccine Trials Network have been laboring for 30 plus years now to try and discover an effective HIV vaccine. And we've had little success, but I don't call them failures because with every downside, we've learned what didn't work. And then we could try now what does work. And all of that research was the foundation, was the platform for the speed for which we were able to develop a COVID-19 vaccine. And so one of the things that I do is to prepare communities, and particularly Black communities, for an eventual HIV vaccine so that they can have the information that they need to make an informed decision when an effective and safe vaccine is available, so that we're not doing the educating in real time the way we were doing with COVID-19. I believe if we knew COVID was coming, if we were a more public health literate society, that less people would have died because we wouldn't have had to do that education in real time. And so really preparing people for an eventual vaccine. We've got some exciting science happening by way of broadly neutralizing antibodies, these antibodies that have been identified in people living with HIV to control HIV. And we've been able to enhance those antibodies outside of the body and then test them in individuals for prevention that could potentially accompany medications like PrEP in prevention, and maybe one day provide us with a way forward for an effective and safe HIV vaccine. So just wanted to add that to the conversation because I think it often gets lost, especially as the medications become more effective, right? We've got an injectable that people can take every 6 months, and they're already working on one that people can possibly take once a year. And so for some people, that sounds like a vaccine. Oh, that sounds like a vaccine to me, right? But with this broadly neutralizing antibody conversation, these are natural molecules that the body has produced And so the risk profile is very low. The side effect profile is very low. And so it's really compelling, especially for Black people who, again, have had skepticism around healthcare and around public health because of the trauma that we've experienced, to be able to say, listen, we are working on something that was produced by our own bodies, that could potentially prevent HIV moving forward. And we want you to be a part of that in clinical trials and research and these types of conversations. And so I didn't want to miss the opportunity to remind us that we still need to find an HIV vaccine if we are to end the epidemic as a public health crisis.
Could I add something very quickly? And thank you so much, Dr. Burley, for talking about broadly neutralizing antibodies. Not only are they potentially really good tools for prevention of HIV, they're also useful for treatment, and they
Yes,
may be an agent that gives us the best promise of a cure. We have
yes,
seen in studies of broadly neutralizing antibodies in people living with HIV that a certain percentage of these individuals are able to control the infection by themselves without medications. So these broadly neutralizing antibodies are somehow interacting with the immune system, and you're an immunologist, doctor, so you know this very well. But there's interactions that are going on that may teach the body how
that's
to
right.
keep this virus under control without the use of any medications. So these are very promising agents that we are studying intensely.
It's really exciting.
This
Can can
conversation has been so good.
can we go back to testing for just
Sure,
a
sure,
second?
sure.
So, in most major cities, um, there are HIV agencies. Like in Chicago, there's Howard Brown. There's the Core Center. I think in Atlanta, you got Grady's. You have Department of Health across the country. You can go and get a free HIV test. So be clear that there are places that test for HIV and they do it for free. Walgreens even have some programs where you can get tested for free. The other thing I want to say about testing is um, Dr. Ulysses talked about it a little, but when you go to the doctor and you ask for a full workup, you are not getting an HIV test.
That's right.
You must specifically ask for an HIV test, or you will not get it. And so it's not automatic. And I find that people think that when they go get their yearly physical, that it's automatically a part of their yearly physical, and it is not.
That's right.
Mhm.
Yeah. Thank you for that
And,
reminder.
and I
So
want to add to the toolbox. And that was such a great conversation. Storytelling can be put in that toolbox because it decreases the stigma, especially in rural
Absolutely.
areas where
yeah.
people can hear other people's stories and how they survived and still surviving being diagnosed with HIV or advanced HIV. But we also need to add another component, and that is mental health. And the reason why I said that
Mhm.
is because for me, I'm not a candidate for the injectables, right? So in my mind, it bothered me, and it played with my emotions and my mental health. Why? 38 years, I remember going from 12 pills to 6 to 2 to 1, and now I'm not a candidate for the injectables, and that really did something to me mentally. So we got to look at those folks who may be going through something because they're not a candidate for the injectables, or they're going to, and we still have some people that are taking 5 to 6 pills um, a day, antivirals. So we also got to look at that. And I think as an individual, people living with HIV learning to take care of themselves, eat healthy. I'm one of those, I don't eat healthy. We got to start learning how to love who we are with this diagnosis. We got to learn how to take care of our bodies and our minds and our emotions with this diagnosis so we can help other people in our community. And I do think storytelling has been working over the last 6 or 7 years, effective storytelling that will help the next person understand that this people are living and striving with HIV and are doing great things, which we all should celebrate that, even those who are working in the field that does not have a diagnosis. We have come a long, long way as Black folks, conquering and slaying all these things that has been coming before us to survive with this epidemic. And we have made some great moves. You know, this is a chess game and or a gladiator game. We are really doing the thing, but I have to agree with Dr. Burley. I don't believe we can totally end this epidemic because all of the vulnerabilities that's out there. It's always going to be a new diagnosis. It could be because a mother is homeless and she may have to do this, that, and then or another, or in the community that I live in, we have an opioid crisis, and it's wild, and people are just having, I mean, they're having sex parties and getting high, right? So it's going to always be some factors that's going to put people at risk for a new diagnosis. But I think that we can have it under control with all the toolbox and the great people that's working toward slowing the rate of infections down.
Thank you so much. I know we are about out of time, so I want to make sure I get everybody's final thoughts. Is there one thing you want to leave with viewers watching today? What message do you want to leave them with from this amazing conversation? I think Tammy kicked it off already. That was amazing. Thank you for that. We'll start with Dr. Burley.
Thank you. So we talk a lot about the social determinants of health, those conditions and structures which people live, grow, work, are born, worship, and relates to their economic stabilities, their neighborhood, their built environment, their access to education and healthcare. But I think the defining determinant of health that we need to be concerned about in present day are the political determinants of health. Politics affect every aspect of our lives and every aspect of our access to healthcare. And right now, we are in the political fight of our lives. And Black people are going to be the most affected because we are people who house multiple marginalized identities as a consequence of the society that we live in. And so we have to be engaged politically. We have to be advocates and activists for our own well-being and for our communities. We have to hold our elected officials accountable, which means that we have to participate in the political process because right now funding is in question. And if funding is in question, then those free HIV tests that Reverend Thornton talked about no longer become available. And if funding is in question, then that means the more than 40% of people living with HIV who rely on Medicaid for their health insurance are in jeopardy. And so we have to be in tune with the political determinants of health and the ways in which people in ivory towers directly impact our health outcomes. And we've got to be prepared to fight, not just for the next 4 years, but possibly into the future.
Absolutely. Thank you. Dr. Crawford.
Well, thank you, Dr. Ulysses. I mean, I have to, a lot of things you said, I probably cannot say, but let me magnify you 1,000 times. It really is so important what you said. Everybody really needs to understand and absorb what he said. I think my message would be is that we have to nurture and treat the whole person. We have to treat their mental health. We have to treat for people who are living with HIV. We have to treat that, but we have to treat everything else. For people who are not living with HIV, who want to protect themselves, there's strategies for doing that. But we have to live healthy lives. We have to eat. People live in food deserts. People eat diets that are almost poisonous. We have to have good nutrition. We have to have good physical fitness and exercise if we're going to live optimal lives. And of course, we have reverends on here and other spiritual. We have to have the spiritual component. We have to have the mental health. We have to have all the pieces to the puzzle in place so that we can be at our best, so that we can live optimal lives. And so I think that's what we all should strive for.
Thank you, Dr. Crawford. Dr. Morrison, your turn.
Well, so much has been said.
Yeah.
I mean, basically, just that these conversations need to be intentional and not kind of one offs throughout the year in observance, because HIV is a pressing issue within so many communities. And I know that it's great to highlight National Black HIV/AIDS Awareness Day, World AIDS Day, Latino HIV Awareness. It's beautiful, but every single day there should be some kind of messaging or conversation to keep this on the forefront. So many lives are at stake, but so much work is being done. And I think that when we fail to have these conversations or have these discussions, we're missing opportunities to keep people in the know. And then they're not overwhelmed and exhausted when we come out the gate with all this information. But if we keep it like this, a constant flow, then people will know what's on the horizon. They will have some hope about scientific research, and we're all in this together. So that's just my takeaway, that these conversations just stay on the constant and not just once every few months.
Thank you. Reverend Thornton, how about you? What's your message?
Um, for those who are living with HIV, people ask me all the time, how do I do it? I do it, yes, by the grace of God, but I have made a decision about how long I live versus how soon I die. And so that's a whole package of taking my medicine, doing what I'm supposed to do. And don't be confused. I was at one point taking 32 pills a day. I've had 3 bouts of pneumocystis carinii pneumonia. I should have died, but I didn't. So now I take 9 pills a day. I have a therapist. Mental health is very, very important. You cannot do this alone. Physical health, you've got to exercise. I'm a sugar junkie, and so now the doctors have made me shame today. But what I'm saying is, while you can live with this disease, you have to be proactive about your life. You have to be proactive about the rest of your life living with this disease. And if you're not living with HIV, you can prevent it. So I'm going to ask you very candidly, use a condom, get on one of these preps, do something to ensure that you will not get HIV. That's it.
Thank you. And Tammy, do you have any words that you want to share, a message? You kicked it off, so I thought I'm going to end it with you.
But I'm just going to say, I am honored to be on this panel with all these brilliant people. But I do want to share this. We must stay focused. We must be spiritual. We must be intentional about who we are as Black folks, right? We have to learn how to love one another, love ourselves, because the days ahead, we don't know what that's going to look like for us and the HIV epidemic in our communities. But we must stay focused. and we must be intentional. And it's okay not to be okay. Get tested. Know your status. It's
Absolutely.
okay.
Absolutely.
Can I just say one last thing, honest to God? I know I
Yeah.
talk a lot, y'all.
That's okay.
But I have been thinking about all of our cousins that are across the continent who have not received their HIV medication because USAID has shut down. That Elon Musk, under the authority of Donald Trump, has shut down USAID, and people are without their HIV medication. And we know that when you stop your HIV medications, that you can set up a resistance to that particular HIV medication. We also know that pregnant women with HIV cannot afford to miss one dosage. And so my heart is so heavy for our cousins across the continent who do not have their HIV medicine tonight and didn't have it yesterday or the day before yesterday. And so we need to do something. We need to take a stand. Call your congressman, call your senator, and demand that USAID be restored. And not just HIV, but there are people who can't get their tuberculosis medicine. And we know that if you don't get your tuberculosis medicine, that you could set up resistance and create a different strand of tuberculosis. And there are people who are hungry right now because the food didn't get unpacked from the ship. And so this is very, very serious. They're coming for our cousins, but we're going to be next. And so we need to take a stand.
Yeah.
Period.
Yeah. Thank you. Thank you. Thank you all for being transparent. Thank you all for sharing your knowledge and reminding everyone to go get screened and to prevent, that prevention is key as well. I want to thank you all for joining us here on BlackDoctor.org. For more information on HIV and AIDS, head over to BlackDoctor.org for articles and resources over there. So thank you again to our panelists, and I want everyone to have a great night.
Thank you.
Thank you.
Thank you.
Namaste.